I'm Ryan Flannigan. I'm the clinical leader for the Sexual Rehabilitation Program here in Module 2. And the goal of today's talk is basically to introduce the program, talk a little bit about normal functioning, what kind of changes you might expect with prostate cancer treatment, and then some of the potential management options that we have moving forward. The overview of what we're going to cover today, we want to talk a little bit about our Module 2 here with sexual rehabilitation. We want to talk a bit about normal sexual function to kind of set the stage to help us understand what can happen with treatment for prostate cancer, and then we can talk about some of the management options beyond that. So our goal is to provide education, supportive care, medical and surgical therapy when necessary to help sexual functioning, intimacy, and overall quality of life in everybody here. So this is kind of a roadmap of what our team looks like. So I'm the medical lead here, and we have several other clinicians involved. So Christine is in the side here, and she's our nurse clinician in the Vancouver site. We have Joseph, Lana, who are both here, and Joseph's going to be starting the Surrey location, and Lana's in Victoria. We also have Nicole and Brittany, who are dialed in here, listening to the talk, in Kelowna and Prince George. So this is a recent initiative where we're trying to expand across the province, make it a little bit easier and more accessible for patients to access this level of care without always having to come to Vancouver if you're not from here. We also have administrative leads, Dr. Higano, who's not here, and Monita, as well as Jenna, who are two administrative leads here that help keep the program running. So we've all probably heard at some point, whether it's at a clinical appointment, reading online, talking to a friend, that treatment for prostate cancer can affect your sexual function and thus, your relationship with your partner if you have a partner. So we want to create a little bit of perspective here, talk about that normal functioning, how we might experience some dysfunction before we can talk about management options. So if we look at intimacy, this is a pretty big umbrella term, but basically it's the affectionate or loving personal relationship with another person. So it can be divided into several subcomponents. Intellectual intimacy, are you on the same page with interests and thoughts and ideas? Experiential, you enjoy doing things and spending time together. Emotional intimacy, you can share feelings, express feelings, and feel vulnerable together. And then sexual intimacy, and all the practices of one's sexual relationship with their partner. So if we dive a little bit deeper into the sexual intimacy, we kind of want to look at what components are involved in sexuality to begin with. And there's a lot of things that go into this whole concept. It's not quite as simple as grade 8 science may have led us to believe. So there's the physical components, there's your thoughts, your attitudes, desires, your values and beliefs of how all those experiences are shaped in your mind. So there's a lot of components that make up each individual's own sexuality and how they express their sexuality. So it's important to consider this when we're breaking it down in terms of how do we help manage these components. We need to first understand that there are a lot of factors contributing to how we feel at any given time. Now, if we look at sexual function, and this is a little flow chart of the steps involved in the process when one becomes sexually active. So first, there's sexual desire and arousal. So you need to have the want or the feel to initiate the process. For men, usually this will lead to erection. You don't necessarily need an erection, we'll talk about that a little bit later, but the next successive action typically is orgasm with ejaculation, otherwise referred to as climax, and then resolution, that happens, the erection goes away, and then there's a refractory period where it's really difficult to get another erection and have another orgasm or ejaculation again. So each of these circles can impact the processes to follow and vice versa. They're all kind of interactive with each other. And there's a lot of factors that can impact each one of these circles. So for the sexual desire and arousal, a lot of factors can play into this. If there's stressors, somebody's not sleeping well, you may feel low mood or depressed, anxious, all these things impact how likely you are to feel in the mood to be aroused for sexual functioning. There's also physical factors, medical factors that can also impact this. Testosterone levels are heavily implicated in this field, the arousal component. Many medications can also impact this, especially in prostate cancer treatment with some of the androgen deprivation therapy can have a really big impact here. Similarly, if erections aren't working very good, sometimes this can add a stressor and create some distress that why would I want to have, get aroused and be interested if it's not going to work? And that's something that we often see. We'll try to talk about a little bit later. Now, erections are a complicated physiological process. A lot goes into it. So there's a lot of things that can also impact it. Outside of prostate cancer treatment, there's a lot of medical conditions over time that can be a factor. Diabetes over time, high blood pressure, cardiovascular disease. The surgical procedures, most relevant, the radical prostatectomy, or if the bladder comes out, usually the prostate will also come out. It's for cancer. Colorectal surgery is also another important one that's getting more attention. Radiation treatment, another one of the primary treatments for prostate cancer. This can be the external beam from the outside or the brachytherapy from the inside. They can also have implications for the erectile function. There's also numerous lifestyle factors, and again, your emotional or psychological state has a significant bearing on erectile function. If you're feeling stressed or anxious, a lot of those molecules that are released in your body are essentially the antidote to erections and can play a really big role in that. Now the last two circles, orgasm and ejaculation. So these often coincide at the same time. Orgasm is the sensation that one experiences with the climax, where ejaculation is the production of the fluid that comes from the end of the penis. Now usually those go together, but if you've had surgery for prostate cancer, prostate's removed, you may still experience that climax or the orgasm, but you won't have fluid coming out. So then they become separate events, if that makes sense. The resolution and refractory period, this is natural, it happens to everybody, but tends to get a little bit longer as we age. So when somebody's 18, that period from having a climax to the next period of time when they can get an erection and have one again is much, much shorter than when we're 50, 60, 70 year older. Now, let's look a little bit more closely at erectile function. So we can get erections from thinking about something, from a sexual touch, or naturally in our sleep, called nocturnal erections or REM-associated erections. Now, all of these erections need a signal to be transmitted from the brain and the spinal cord through your pelvis to the muscle in the penis. Now, when the penis receives this signal from the nerve, there's a whole bunch of events that happen that essentially lead to more blood going into the penis. The muscle that makes up the majority of the penis relaxes. It catches this blood, and then it seals off all the veins leading out. So that blood gets trapped in there, and that's why the penis will expand and get firmer. Okay, so it's blood going in and being trapped there. Now, these nerves that I mentioned that run from the spinal cord through your pelvis to the penis that are responsible for triggering these erections are these yellow things here that run directly adjacent to the prostate. So they are cell layers thick from the capsule of the prostate. So they are very, very, very close. And they're critical for these erections. So obviously, with prostate cancer treatments, these are at high risk for being injured. So if we look at the top left, that's a snapshot from a radical prostatectomy, so surgery taking the prostate out. And if you can see, there's some little lines there that are supposed to represent the nerves kind of on the sides of the prostate that the surgeon has to scrape off or incise just in that very, very subtle plane, we call it, between two different tissues to get them off, but still get all the prostate cancer out. So it's a very fine line, and sometimes if the cancer is more advanced on one side, those nerves cannot be spared. And occasionally, if it's very advanced on both sides, then the nerves have to be taken at the same time. Similarly, with the radiation therapy, there's a couple of different kinds, but if we look at the external beam radiation, that's the photo on the top right, and basically it provides radiation from multiple different directions to focus on the prostate, but there's always a little bit of collateral damage in the regions adjacent to that focus where the prostate cancer is, and those nerves fall within that region. This is similar with the brachytherapy, the bottom left, where they insert the beads into the prostate, which each bead emits some radiation to destroy the tissue adjacent to it. So to get the entire prostate, oftentimes it will be affecting those nerves that are so close to the edge of the prostate. Okay, so that's kind of the premise of how prostate cancer treatment is so heavily involved with erectile function. Now, what happens if you injure one of these nerves? Well, that signal doesn't go to the penis, and over time this nerve may regenerate to a certain extent, but in that time period when it's not working properly, that muscle becomes more fibrotic and stiffer, and it doesn't carry the same ability to trap that blood in. So then all of a sudden, we have that blood leaking back out, and it can't maintain that same pressure needed to have a firm, rigid erection. So we can almost think of it, if we're filling a bicycle tire and we're putting air into that tire, but there's little punctures, no matter how much air we're putting in there, it just won't get firm. And that's kind of the same events that happen with what we call venous leak within the penis, is that no matter how much blood we put in, it just continues to leak out, and that muscle isn't elastic and strong enough to trap it in and keep a rigid erection. Now, the other thing that's important to know is how different treatments impact erectile function with prostate cancer. So surgery, things happen in real time. If a nerve is going to be damaged, it's damaged at the time of the surgery. So most of the drop in erectile function happens immediately, or at least within the first 6 months. So if you look at the graph at the top, you can see there's a dip in sexual function or erectile function here, and then over time it tends to get a little bit better. We think that time period is likely within the first 2 years. There's some data to suggest that there's some improvement in erectile function up to 4 years after surgery, but most of it happens between 6 and 24 months. Okay, so that's the period where your body's regenerating and things are getting a little bit better. However, if you look at radiation therapy, just the mechanisms of how this works, you receive the radiation therapy, and then over time the changes take place, and the tissue becomes more fibrotic and damaged. So the erectile function initially doesn't necessarily change much, but in years and years to come, it drops off more rapidly than if we didn't have any treatment at all. And that's represented by the bottom graph, where erectile dysfunction goes up over time on the x-axis. So this is a table we put together just to try to compare and contrast what happens with some of the different treatments with prostate cancer with respect to sexual functioning. So active surveillance is something that we'll do if it's a lower grade of prostate cancer, and we want to keep an eye on it. We don't necessarily have to do a definitive treatment immediately. So in this case, there shouldn't really be much change to erectile function, although we do see a little bit, and this is most likely implicated, we think, due to some of the stress and anxiety surrounding the diagnosis and monitoring this. So that can have a slight decrease. Similarly with your sexual drive and your arousal. Like we were talking about at the beginning of the talk, all those factors have a strong association with how you feel and process stimuli, and which links back to your sex drive and your arousal. Beyond that, there's not really any changes to ejaculation, orgasm, urinary incontinence, bowel issues, etc. Okay. Now, if we look at surgery, prostatectomy, sex drive is probably a little bit lower initially when you're healing from surgery, and it's probably lower down on your list of things that you're thinking about and worrying about. But over the long run, it shouldn't have much of an impact from a physiologic basis, but certainly could from a psychological and emotional standpoint. Erectile function decreases immediately, like we said, between 6 and 24 months may increase a little bit. Orgasm can change for some. Some people find that the intensity of orgasm is the same. Some will find it a little bit better, some find it a little bit lower. And then a small percentage, maybe about 15%, will have some pain in their pelvis at the time of orgasm or climax. And we think this is typically a temporary thing and due to muscle spasms in the pelvis. But the thing to know, you will not have any semen come out. So there will not be an ejaculate because that section of plumbing was removed. Okay. Urinary issues, some people will have some leaking. Again, worse initially and tend to get better over the 6 to 12 months. But specifically with sexual functioning, some people might have a little bit of leakage during stimulation or at the time of climax. And if that's the case, we have some different options of trying to navigate this and manage it. So that's important to know. Otherwise, bowel issues and other issues are pretty limited. For radiation therapy, this dysfunction happens a little bit later, like I mentioned, and tends to be progressive over time. And sexual drive, similar to the impact on surgery, sometimes the psychological stress and emotional toll will have an impact there. But a special note is if you receive androgen deprivation therapy, so hormone shots, at the same time of radiation, which sometimes happens, that will significantly decrease your sexual drive or your desire, just because we really need testosterone to generate that feeling from a male perspective. With respect to orgasm, there can be some changes as well. Some of the tissue becomes a little bit more fibrotic and less healthy in the prostate region. But for the most part, it's fairly unchanged, and the sensation should be pretty similar. The ejaculate, so the fluid coming out, will sometimes decrease a little bit. Occasionally it'll disappear, but oftentimes there will still be some ejaculate that comes out. Urinary issues, they can also be present. They tend to take a slightly different shape than surgery. Sometimes people have more difficulty peeing or emptying their bladder, frequency, blood in the urine, sometimes leakage of urine as well. It's a little bit more variable with this, but it's also variable from the perspective of some people will have some of these symptoms and some people won't have some of these symptoms. So it's really individual at that level. Bowel issues, because the radiation is so close to the rectum, the prostate and the rectum pretty much are very intimately related. They're kind of two structures nearly attached to each other. And with that, sometimes the radiation, because there's that region around where we're focusing it, can also affect the rectum, and some people will have some bowel symptoms as well. And then the last one, androgen deprivation therapy. So these are those hormone shots meant to decrease your testosterone. The reason this is done is prostate cancer needs testosterone to function and grow and increase. So one of the main treatments that we use for advanced prostate cancer is to remove the testosterone, which is kind of like removing the fuel from a vehicle to limit what it can do for a period of time. So this can have a significant impact on your arousal or your sex drive. It can also have a decreased effect on your erectile function, and ejaculate volume as well will also go down. Shouldn't really have an impact on urine or bowel issues though. Some other things with the androgen deprivation therapy, our body is so dependent upon our hormonal status. Sometimes we can gain weight, we can get tissue growth in our breasts called gynecomastia, swelling, decreased energy or fatigue. Those are all things associated with it. And like I said, we have another module that addresses this, and if any of you are on that, that might be a really helpful module for you to learn more about this. Now, some of the factors that are predictive of erectile dysfunction after treatment include what age you are to start with. So typically, younger men will have slightly less impact on erectile function. If we have other medical conditions that also contribute to erectile dysfunction, like diabetes, hypertension, those can also worsen the results afterwards. The most important thing, though, is how strong your erections were going into treatment. So if you had really good erectile rigidity prior to treatment, then that's a good predictor that you'll hopefully have good erectile function after treatment. And then the type of treatment is also really important. So if you had radiotherapy, what type of therapy? If you had surgery, was there nerve sparing? Was it complete? Was it on one side or both sides? And oftentimes that's really dependent upon the location and the grade of the cancer, and how the surgeon will interpret that in terms of, looking after your cancer cure is the number one, and then preserving the sexual function is the other options. Now, the important thing to know is, scared everybody in terms of how all this stuff works and what these treatments can do. But the important thing is that there are certainly lots of options, and you can still be intimate and have a really good sex life after treatment. Just sometimes requires some additional steps, some additional therapies, but we can get there. Now, some myths that we want to kind of debunk right off the beginning is that there's multiple here. So people that have health challenges really don't have any interest in sex anymore. Well, that's not the case, because nearly all of us have at least one or multiple medical conditions, and most of us through our life will have at least 3 medical conditions, and 1 in 3 people, or roughly, will be affected by a cancer. Male orgasms require an erection. Not true. Everybody can experience an orgasm even with a penis that's flaccid or soft. You don't need an erection to acquire a climax. Sex is obviously not just for young people. Good sex requires orgasm. Absolutely not. It's about multiple factors and the connection with your partner, and not just the couple seconds of climax at the end. So just kind of reframing and looking more at the process is important there. Sex education is only for disease prevention. Obviously not the case. Education is very valuable throughout the steps. It's helpful if you know things going into something, but it's also helpful knowing things once you've had it, and we're looking at what can we do now. Sex should be spontaneous, no planning and talking. So this is a really important one. Sometimes some of the management options involve a little bit of planning. It might mean taking a pill, it might mean an injection or a pump, or even communicating with your partner ahead of time and figuring out good strategies to make events successful. And that's absolutely okay. And for some couples that will be an adjustment, and other couples that will be something that they might already have experience in. Sex means sexual intercourse. That's not the only form to be expressive, and there's lots of other potential options to be sexually intimate with your partner. Men should initiate sexual activities. Not always the case. It can easily be their partner, and that's, I think, a couple-dependent thing, and something that may require just a little bit of communication, especially once things change. If you're on the other side of treatment and you have noticed some changes, having those conversations can be really helpful, and we'll talk a little bit more about that. So how do we go about managing these things? Well, one thing is you can work with some of our health clinicians within our program. Communication is extremely important, and we'll talk about that a little bit. Sexual adaptation is just a concept of understanding that there have been some changes, and how do we navigate these changes now, either by yourself or with your partner. Refocusing on intimacy with your partner, and then there's multiple different treatment options for erectile function, which can be pretty important in this process. So communication. So talking and communicating is extremely important. Some of the studies out there would suggest that having good communication with your partner is amongst the most predictive factors in your sexual satisfaction. Okay, so it's important to say it again. So having good communication, open dialogue, being on the same page is one of the most predictive factors in how satisfied you're going to be on the other side of treatment. So that's really important. And having these talks with your partner, again, everybody comes from different experiences and relationship dynamics, but if you've never talked about this, initiating that and just starting with some conversations can be really helpful. If this is something that has been part of your relationship dialogue to date, then just building on that and expanding that can be really, really helpful in ensuring that everybody's on the same page. So, how do you do this? Sometimes just, breaking the ice in the beginning, engaging that conversation. I think coming to sessions like this, so there's education there to start with, and everybody's aware that this is something that's really important, can be really helpful. And just being honest of where each person in the relationship is coming from, and talking about each other's understanding of where things are at can be really helpful. If this is really challenging, sometimes engaging another person, a counselor or a sex therapist, which is just another term for a health professional that's been well-trained in relationship dynamics and sexual encounters. So those are all things that we can help couples get connected with through the program here. Now, we bring this figure of the intimacy back. So when we think about being intimate with their partner, I think naturally many of us always focus on the purple sexual little bubble. And especially in the case when something's not working as well as it was before treatment, it's very easy to really focus on this because we want to help it to make it better. But with that in mind, we also have to remember that there's all these other ways that we are intimate with our partners, and we can't forget about those and just put all of our focus on the one that's maybe not working as well as it was a few months back or a few years back. So just remembering to continue to put effort and focus on these other areas in addition to what's recently changed is really important. Now, a lot of this talk has been about having a partner and engaging. It's all the same principles and concepts if you don't have a partner, if you're single. So all these same treatments and concepts are still applicable to any single individuals here. And if you're looking to start a new relationship, you may feel that it's daunting or challenging now that there have been changes in place. but it's just really important to apply the same principles and, being honest and communicate clearly with your potential partner is what we find to be really helpful from our experiences in interacting with men. Keeping it simple is often a good principle here too. So the concept of sexual adaptation. So here, basically what it means is that many of us have probably experienced some changes, and in dealing with these changes, we want to deal with them in a way that's helpful for us. So this may mean that we have to accept that things may be slightly different than they were 6 months ago or 6 years ago, but we can still optimize where we're at, have the flexibility in considering trying different things, pursuing clinic appointments with sexual health clinicians through the program here, having patience as things heal and regenerate, and persistence. So continuing to try new things, try different medications if we're trying to get the erections working better, try different forms of treatment, persistence in communicating with your partner, and trying different activities beyond just penetrative intercourse. So those are kind of the fundamental structures of sexual adaptation that's important to keep in mind kind of moving forward. Now, relevant to our program, we talk a little bit about sexual rehabilitation and penile rehabilitation. So these are kind of the processes in allowing us to help guide optimizing all these different dynamics and components that we've talked about today. So if we talk specifically about penile rehabilitation, this is a concept that's been in the literature for the past 20, 25 years or so. And the idea here is that after a treatment, we have a decrease in erectile function for most men. But if we can continue to stimulate that muscle and exercise that muscle, the erectile function down the road or the improvement might be a little bit higher than if we did nothing and waited. So this could be as simple as just self-stimulation or stimulation with your partner on a regular basis once you've healed up from the surgery or following the radiation therapy. It could involve taking pills like Viagra, Cialis, those kinds of things, or doing little injections into the muscle of the penis, or using a vacuum therapy. And the idea here is that if we exercise that muscle, so it continues to work, there's less chance of it becoming stiff and fibrotic with that, remember the leaky tire analogy? So that's what we're trying to avoid. And conceptually, from several lab-based experiments and some human-based experiments, we think that exercising that muscle keeps it healthier and gives you a better chance of having better erections once everything else is healed in your pelvis from the surgery, if that's the treatment that you had. So that's the overall concept. There's different ways of getting there, but overall, studies that have looked at individuals that have undergone this process and have put a strong effort to staying active on a weekly basis, either alone or with a partner, suggests that the erectile function recovers by nearly threefold compared to those individuals not pursuing any of these potential options. Now, we touched base a little bit on ways of treating erectile function. So the most, or I guess the initial approach that most of us will typically pursue is some of these oral pills. PDE5 inhibitors, that's kind of the name you may hear get thrown around on platforms online or in the clinics. But basically it's just a class of medications that represent the Viagras of the world, Cialises, Stax, and Levitra. They're medications that essentially help that muscle relax within the penis to trap that blood to a more effective level. Okay, so it's right at the interface where the nerve meets the muscle, and that's where it acts, and it helps with the venous leak, so trapping that blood in the penis to have a more rigid erection. So typically using these medications, they're all slightly different formulations, but one would take a pill maybe an hour or 2 hours in advance. Your body would absorb it. You need the same stimulation that you typically have, and this would just enhance the ability to get a firmer, stronger erection than you typically would without it. Okay. Now, another treatment form, we don't use this one quite as commonly, but you can deposit a medication within the P channel, the urethra of the penis, and that gets absorbed to help make an erection. Just due to the application, we don't use this one as commonly, but it can be effective for some individuals. Penile injections is one that we typically use more commonly. It's quite effective. The medication is fairly potent. There's various different medications that we can use here and combinations of medications. But for the injections, this is typically something that we might use if the pills aren't working. We would teach you how to do this in the clinic here, ensure that you're comfortable, and then you would administer this at home either by yourself or with your partner. And essentially you'd use a very, very small needle, inject this small amount of medication within the muscle of the penis through one quick poke. Once you're trained on it, that takes just a couple seconds. 5 to 10 minutes later, once we find the right dose, if it's effective, we'll get a good strong erection, and that typically lasts anywhere between 30 and 60 minutes. Again, once we find that right dose for you. So this typically is quite a strong medication and can work quite well. Vacuum therapy is another one. So here there's a cylinder that would go around the penis. So the penis is inside the cylinder, and there's a pump that essentially creates a negative pressure. It moves all the air out from inside the cylinder, and that pulls the blood into the shaft of the penis to essentially induce an erection. And there's a little band that's on the base of the cylinder that you would slip off, and it would go at the base of the penis to maintain that blood and keep it within the shaft. And then you could use this for either activity by yourself or with a partner. So this is another quite reasonable option for individuals that maybe the pills aren't working, or there's a reason you don't want to use pills or injections. And the last option is a surgical option. It's called a penile implant. And here what we would do is we put these two little cylinders inside the shaft of the penis. There's a pump that's placed within the scrotum, and then a fluid reservoir that we tuck back behind the bladder. And essentially you'd squeeze the pump, and it moves fluid from the reservoir into the cylinders within the penis. And after a number of pumps, those cylinders become very firm, and the penis is erect and firm, and is certainly firm enough for penetrative intercourse. So this is something that we typically reserve if the other options aren't working well and we'd like to pursue something. It's a day procedure, so it takes about an hour or so to do the procedure. Come and leave the same day. You're asleep while it happens, and most people are quite happy with this after prostate cancer treatment, about a 90 to 95% satisfaction rate. So that's another good option if the more conservative options aren't as effective. Okay, so how do we begin? Engaging with our prostate cancer support care program is a good start. We know how to navigate a lot of these things, and we have a lot of resources that we're happy to share and help with. Getting an appointment with one of our sexual health clinicians, either here in Vancouver or at some of these satellites across the province, would be quite helpful. They're very well trained. If there's distress and you think you'd benefit from seeing a counselor, then let us know, and we can get an appointment with our module 6 counselor or a community sex therapist to help with this. And the sex therapist and counselor can be really helpful in just working through the process of distress out of ourself or with your partner, and as well as our sexual health clinicians can also be very helpful in navigating, sexual adaptation and helping you through that process and optimizing all the factors that we can for you. And like I mentioned before, it's just so important to talk to your partner if you have one. And that communication is one of the most important factors that the literature would show that leads to satisfaction and sexual satisfaction specifically for you and your partner. So that's a really important one to take away from today. Okay. So there's many other options beyond penetrative sex that are important to consider, and keeping an open mind with some of these things and changes. So overall, prostate cancer treatment may impact your sexual functioning through many of the different ways that we've talked about today. And our program's here to help you. We have a lot of resources, clinicians, we're plugged into physiotherapists, other medical physicians, surgeons, counselors, psychologists, etc. So use us, let us help where we can, and our door is always open, and if you have any questions, I'd be happy to take them.